I'm excited to welcome you to this orientation session that will provide an overview of pyramid model implementation in Part C early intervention programs. This session is brought to you by the Parent Infant Early Childhood, or PEAK team, at the University of Connecticut School of Social Work's Innovations Institute. The session will begin with a broad overview of what the pyramid model is, what the critical elements are in implementation, and some of the different activities providers and programs engage in as they are working towards pyramid model implementation. The purpose of this initial session is to provide both program leadership as well as individual providers with an increased understanding of the range of activities you can expect to participate in as your system begins implementing the pyramid model. The pyramid model is an evidence-based public health framework that focuses on social and emotional development in children from birth through 5. Originally, the pyramid model was developed and used in infant, toddler, and preschool classrooms, but the principles have now been expanded and adapted to support broader work with this age range, including, importantly, the early intervention workforce. The model itself is pretty easy to understand. It applies a public health framework to social and emotional supports for children and families in care. Starting from the bottom of the pyramid image, the base of the pyramid is an effective workforce. This is you. It's critical that individual providers have the knowledge and skills to implement pyramid model practices, and that programs have policies and procedures in place that support pyramid model implementation. The blue section is Tier 1, which is considered universal promotion, and it includes universal activities that ensure social emotional development in all children. Tier 1 is comprised of nurturing and responsive relationships and high-quality supportive environments. When we think about nurturing and responsive relationships in Part C, the main focus is on supporting the relationship between the caregivers and their child. In other words, how do you, as the service provider, help the caregiver demonstrate warmth and responsivity to their child so that the caregiver-child dyad is strengthened? And here, when we're talking about caregivers, we're talking about parents, grandparents, foster parents, any other caregiver who would be involved. Having a strong relationship with a caregiver is crucial for developing secure attachment, which is a necessary condition for healthy interpersonal relationships throughout a child's life. Further, if a child is demonstrating behaviors that challenge the caregiver, it will be incredibly difficult to support that child in changing their behavior when their relationship with their caregiver is strained. This makes sense. Think about if you are having trouble at work and your supervisor is trying to get you to do something different to be more effective at your job. If you have a good relationship with your supervisor, if you have the feeling that they want what is best for you and that they work from the assumption that you are doing the very best that you can, you're probably more likely to try to make the changes than if you have an average or poor relationship with your supervisor and don't really feel like they care about you. While the focus is on the caregiver-child dyad when we think about pyramid model practices, it's important to also consider how you as the provider work to develop a relationship with the caregivers. It's obviously a different kind of relationship, but the same principle applies where you are in a role that involves coaching a family to try something new or different to support their child. If the caregivers see you as someone who is responsive to their values and parenting beliefs, and someone who has their and their child's best interest at heart, they're more likely to try some of the strategies you're offering. The second component of Tier 1 is high-quality supportive environments. This refers both to the physical environment, like the setup of the family's home, but also some of the structure, things like family routines. Using the routines-based interview, RBI, the SAFER or something similar, the provider can gather information about what routines or times of day can be challenging for the family and identify routines or structures that might help caregivers move through those routines more smoothly. Tier 2 is considered the prevention level, and it represents targeted social emotional strategies that will be needed for some, but not all children. This includes explicit instruction on social emotional skills, for example, identifying and labeling emotions, emotion regulation strategies, problem-solving skills, and friendship skills. Here again, the idea is that providers feel confident in having discussions with caregivers about their children's social emotional skills, and that they're able to support caregivers with strategies to teach their children social emotional skills as necessary. Tier 3, the top of the pyramid, is considered the intervention level, where an individualized intensive intervention may be necessary to support the child. While many children who demonstrate needs at the Tier 3 level may respond to a behavior support plan, some children may also need additional referrals to outside providers. For example, a child who has experienced significant trauma is likely to need counseling support in conjunction with a behavior support plan. The goal of Pyramid Model in Part C is that providers can help caregivers in implementing strategies for Tier 1 and 2, and that providers are able to initiate, if not complete, a process for supporting a child who would benefit from an individualized intensive intervention. Ultimately, the provider may want to bring in a social worker or other staff person with behavioral expertise during this process, but the goal is for all providers in the system to feel competent in understanding when a Tier 3 intervention is necessary and participating in developing the plan for that child. As mentioned at the beginning of this session, the pyramid model began in classrooms, but has since been adapted to meet the needs of other workforce in the field, including Part C early intervention systems and providers. The pyramid model aligns easily with the family coaching model, where the idea is that pyramid model practices help early intervention providers to build their confidence in supporting the social and emotional development of children and a framework for addressing this domain with families. Through the pyramid model framework, early intervention providers help families increase their capacity in both understanding and attending to social and emotional and behavioral concerns, with the result that families engage in practices that support their children's social emotional development. There are 5 primary principles that support pyramid model implementation in Part C. The first is that practitioners build collaborative partnerships with all families. We talked about this briefly at the beginning when we reviewed nurturing and responsive relationships in Tier 1, but it's worth reiterating here that it is foundational for providers to work on developing good relationships with each family they serve. The second principle is using family coaching strategies to meet families' needs. This is a great place to see the overlap between the pyramid model and other EVPs, where Sheldon and Rush reflective coaching practices give providers the strategies they need to coach families effectively. The third principle is providing families with knowledge and skills to help them develop nurturing and responsive relationships with their children. For some caregivers, relational skills like talking with their baby or toddler, providing physical warmth like hugs and cuddling, and engaging in play with them will come naturally, but other caregivers will need support with this. The importance of a strong relationship between caregiver and child cannot be emphasized enough, both for meeting the child's immediate needs and also for their lifelong capacity to develop strong relationships. The fourth principle is helping build families' confidence and competence in supporting their child's social emotional development. We want families to feel like they have the tools to support their child. This doesn't mean that they'll never need outside assistance, but we want them to feel sturdy in their knowledge of social emotional developmental milestones and their capacity to help their child progress in their development. The final principle is giving families tools and strategies to help them prevent challenging behavior, which is a skill that we often hear requested by early intervention providers. Providers who use pyramid model practices help caregivers better understand the meaning behind their child's behavior, which allows them to identify effective strategies to both prevent and respond to the behavior. Now I'm going to shift gears a bit and talk about the activities that comprise pyramid model implementation. We will start with program level activities and then move to provider activities. One thing that's really critical to understand is that it truly takes a program-wide effort in order to make pyramid model implementation work. This means it can't be just a few providers doing their work in a vacuum, but there really has to be a coordinated effort across the system that supports implementation. Because there are both provider activities and program-wide activities, it's critical to understand that true implementation of the pyramid model is a multi-year process. We'll talk more about the different stages of implementation in an upcoming information session to help provide a roadmap for what implementation will look like. The benchmarks of quality, or BOQ, is the program-wide fidelity measure of pyramid model implementation. We'll look at a snapshot of the BOQ in a couple of slides, but for now, I wanted to take a minute to talk through the 6 critical elements that programs work to implement. Each of these critical elements contains multiple indicators that flesh out the activities designed to facilitate their completion. The first critical element is a leadership team. This leadership team is comprised of multiple stakeholders, and it's responsible really for keeping the implementation work moving forward throughout the program. The leadership team should meet at least monthly, and the team will set goals and action plans based on the results of their annual BOQ. Another information session will follow this session with additional information, further detailing what the leadership team is, who's on it, and why it's important. The second critical element is staff readiness and buy-in. One of the tasks of the leadership team is to ensure that staff have enough information about what pyramid model implementation is so that they can make an informed decision about whether or not they want to pursue implementation. Think of this as kind of like an informed consent for beginning this EBP. We know that it is nearly impossible to have successful implementation of any new practice without buy-in from the folks who will be responsible for implementing the practices. The third critical element is family engagement. It's really important to have family voice and family feedback regarding interests and perceptions of pyramid model implementation. And while there are multiple ways programs can engage families so that the services authentically meet families' needs, one important way of engaging families is to have family representation on the program leadership team. Another critical way to engage families is by offering positive solutions for families, or PSF, groups in your communities. PSF groups are designed to show caregivers how pyramid model principles can be applied in the home. The fourth critical element is building staff capacity. I'll talk about this a little bit more when I talk about provider activities in a couple of slides, but another important piece is ongoing professional development, and this includes not just training, but ongoing coaching. This increases capacity for providers using pyramid model practices. The fifth critical element is providing interventions to children with persistent challenging behavior. I talked about this very briefly when talking about Tier 3 interventions, but this section really addresses program-wide supports and resources that help providers support families when there are persistent challenging behaviors that don't resolve with Tier 1 or Tier 2 strategies. The final critical element is monitoring implementation and outcomes. Collecting fidelity and outcome data is a central component to pyramid model implementation, and identifying ways to use that data to inform implementation strategies that will enhance outcomes for children and families. We discussed the BOQ previously, which is the fidelity tool for program-wide implementation. Another source of data is the Early Interventionist Pyramid Practices Fidelity Instrument, or EPFI, which is a provider fidelity tool. Social emotional screening activities and IFSP goals related to social emotional development are additional sources of data that can be tracked. We'll talk more about using data to inform implementation activities in a future information session. In order to fulfill the indicators discussed above in the BOQ, there are activities that take place at a program-wide level and at the provider level. At the program level, the pyramid model leadership team is established and meets monthly. As a reminder, this team is comprised of multiple stakeholders like administrators, providers, family members, really just wanting to ensure broad representation on that team. The PLT completes the BOQ at least annually and develops an action plan based on the results and the priorities of the program. In order to facilitate staff buy-in and family engagement, there is consistent information shared with staff and families about pyramid model activities, and input from staff and families is regularly sought out and used to inform what the priorities and activities are in a program. The PLT develops a plan for ongoing professional development that includes both initial training and ongoing coaching, and or shorter professional development sessions for staff across the program. Throughout implementation, data are collected and used to monitor fidelity of implementation, child outcomes, and to help identify ongoing areas of professional development. Finally, at the program level, there are facilitators who are trained in PSF, which again is the caregiver group where pyramid model content is adapted to be used at home. Individual providers can also anticipate participating in a range of activities that will support pyramid model implementation. Providers will engage in initial training as well as ongoing professional development that might include individual coaching, group coaching, and if necessary, additional training sessions. Providers will be supported in identifying system-wide practices for screening for social emotional concerns, for example, by universally using something like the ASQSE with all children. One of the main goals in using pyramid model practices is to help families set goals around their children's social emotional development or behavior concerns when this is an indicated need. As mentioned earlier, the expectation is for providers to use a family coaching model for families, and more specifically, to use Sheldon and Rush reflective coaching if providers have been trained in this model. Finally, it's important to recognize that there may be times when providing referrals to outside resources is indicated for a child or family, and we hope to increase provider confidence and competence in identifying when this is the need and what referral sources may be appropriate. The hope is that through a several-year process, programs will approach fidelity in pyramid model implementation. This means that there are consistent efforts in implementation at the programmatic level, that providers are using pyramid model practices with fidelity, and that there is internal capacity for programs to provide training and coaching for their staff on pyramid model practices. This supports sustainability of the model. Although Maryland has been engaged in pyramid model activities as a state for over 15 years, historically, the focus has been on providers and teachers participating in training without participating in some of the other activities. We want to emphasize that in order for there to be true change in how a program approaches the work, there must be engagement in activities at each of these different levels. The next couple of slides are to give snapshots of the tools to assess fidelity of pyramid model implementation. This first image is taken from the FB, which again is the fidelity tool for providers who are giving direct service to families. The FB is divided into 6 categories of indicators: building partnerships with families, social emotional development, family-centered coaching, dyadic relationships, children with challenging behavior, and social emotional assessment. More information about the FB and how to use it will be provided during pyramid model training and coaching. This image is the first page of the BOQ, which is the program-wide fidelity tool that I referenced earlier. And again, as a reminder of the different elements or categories of indicators on the BOQ, there are 6 of them. leadership team, staff readiness and buy-in, family engagement, building staff capacity, providing interventions to children with persistent challenging behavior, and monitoring implementation and outcomes. Although completing the BOQ is the responsibility of the leadership team, and therefore not all providers will engage with the BOQ regularly, it is the job of the leadership team to keep all staff and families informed of the goals and activities that the team is prioritizing to support implementation. So even if you're not a part of the team that's completing the BOQ, you will be hearing about goals and activities that come out of BOQ completion. Over the last several years, our team has supported pyramid model implementation in other SISIP jurisdictions, and there are some important lessons we have learned in this time. The first is that RBI, reflective coaching, and pyramid model work in concert, not competition, to support Part C providers, and this results in positive impact on cause outcomes. Programs are at all different stages with regard to implementation of these 3 EBPs, but regardless of how far along a program is with any of them, each EBP supports the others. The second lesson is that moving to a family coaching model increases the frequency with which families express concerns around social emotional development or behavior to their provider. This makes sense because providers are spending more time with the caregivers as opposed to only working with the child. Knowledge of the pyramid model gives providers more comfort and competence to talk about social, emotional, or behavioral concerns with families, even if this is not something that was part of your formal training. Finally, it's really critical for programs and individual providers to have an understanding of how long true implementation takes and what the necessary activities are that will support implementation. As we talked about previously, there are a number of activities that programs and providers need to engage in. And even when this happens consistently, it still takes several years to see full implementation. So our suggestion is just to expect that this will take a while, and that's okay. And as much as possible, really try to embrace the process and try not to worry too much about when your program or when individual providers are going to reach fidelity. In closing the session, I wanted to take a minute to talk about the relationship between RBI, reflective coaching, and the pyramid model. Completing the RBI, or the SAFER, if your program is using the SAFER, helps families and providers identify daily routines and interactions or elements of these routines that are difficult for the family. This can give a window into opportunities for identifying social, emotional, and behavioral strengths and needs. This conversation also normalizes for families and caregivers the concept that you are a resource to them for these types of issues. For this reason, in many cases, you will find it more natural for families to share concerns or questions about their child's behavior and how to support their social and emotional developmental needs as well. The pyramid model increases providers' capacity to coach families on social, emotional, and behavioral concerns that are identified through the RBI or SAFER or through family conversations. And reflective coaching gives providers the skills to use a family coaching model to facilitate caregivers increase confidence and competence in supporting their child's social, emotional, and behavioral needs. So the integration of these EBPs offers providers a complete toolkit for supporting families to increase their child's social and emotional development. While the last visual illustrated the integration of these 3 EBPs over the course of a case, we wanted to also illustrate here how, as an early intervention service provider, your incorporation of these practices supports your skills and comfort with each. We can explain this a little bit more. The more you use pyramid model practices within your work, the more confident and competent you will feel during these conversations. You'll have guidance to give, and this can reduce any anxiety or concern you might currently feel when you are expected to understand, for example, how to stop a toddler's tantrum. This confidence allows you to easily navigate anything that is raised during the RBI or SAFER interview, and for your reflective coaching skills to support the family on all relevant domains of development for their child. In the next couple of months, you can expect to see additional information sessions on establishing the pyramid model leadership team, pyramid model implementation stages and activities, and using data to inform pyramid model implementation. If you have any questions in the interim, please reach out to us at peak@uconn.edu. Thank you so much for watching this session on pyramid model implementation in Part C, early intervention. And more importantly, thank you for all the work that you do to support children and families in your communities. We are really looking forward to working with you.